All right. So tonight we're going to talk about caring for patients that are in shock. There's a couple different types of shock that we are going to be talking about. Oops, hold on here. Oops, now I lost mine. Hold on. All right, so caring for clients in shock. So your objectives for this material are that we are going to be able to define the different types of shock. There's 4 general categories. We're going to be able to list all those pathophysiologic consequences of shock. We're going to be able to relate the 3 stages of shock. We're going to be able to identify 3 physiologic mechanisms that attempt to compensate for shock. And then we're going to discuss signs and symptoms manifested by clients that are in shock. Oops. Oh, God. We're going to be able to name 3 diagnostic measurements used when we're taking care of clients in shock. We're going to give 3 medical approaches to be able to treating different types of shock. We're going to talk about the different complications that we see with these different types of shock. And then we're going to be able to interpret the nursing management, how we care for these patients that are in shock. All right, so when we talk about somebody that's in shock, shock by definition is the body being in some state where something's going on in the body and our organs are not getting properly perfused. So whenever we don't get proper perfusion to any of our organs, we know that eventually that if we don't intervene, it can cause organ failure that can be or not reversible. It's going to impair all of our cellular function in our body. And when we think about anything that leads to organ failure, that's just, no perfusion to those organs, and then essentially no oxygen as well. Because if we're not perfusing our organs or our brain, we're not getting any oxygen there as well. So one of the things you need to think about shock is that it happens pretty quickly. It's definitely life-threatening. We see a lot of people that go into shock when we think about our little old ladies and our old men who get UTIs. They can develop septic shock pretty easy. So it is rapidly progressing and it is definitely life-threatening. Being able to detect septic shock or shock in a patient early is going to offer the best chances for the patient. So if you're wondering what type of conditions cause someone to develop any type of issue in the body that's going to cause decreased blood volume. So if you're bleeding, if you've been shot, if you've been stabbed, any kind of traumatic injury where you're losing a lot of blood, if you've gone to surgery and something happened during surgery that wasn't supposed to happen and you're, hemorrhaging or you have a lot of internal bleeding. So if we're losing our circulating blood volume, obviously that's depriving our organs from the perfusion and the oxygen that they need. So that develops into shock. About heart failure. So right-sided heart failure, left-sided heart failure, CHF, all of that can cause us not to be able to pump out an adequate amount of blood into our body, which is supposed to perfuse our organs. So if the heart's not working, and then any type of issue that would cause our vessels to dilate. So if we make our vessels a lot bigger than they are, our blood's going to go through a lot faster and it's not going to be able to perfuse anything. So we're going to go into detail and talk about these different issues throughout this evening. So you guys need to understand, like I said, it happens very quickly. It can definitely compromise someone's life, and it's going to ultimately end with organ damage, which may or may not be reversible, and then, of course, death. So the 4 categories that we're going to talk about are hypovolemic, distributive, obstructive, and cardiogenic shock. So hypovolemic shock. So if you think back to early on in 111 when we were talking about fluid and electrolytes, and hypovolemic is just that low volume, right? Low circulating volume in our body. So we think of someone that has hypovolemic shock if their intravascular volume, our circulating blood volume, decreases from its norm to anywhere between 15 and 30% less, which is a lot. So anybody that's losing that amount of blood or is dehydrated to the point where they've lost 15 to 30% of their circulation, that's going to cause them to have hypovolemic shock. So people at risk factor are people that are losing a lot of fluid. So these are our patients who maybe are on diuretics and they're not taking adequate fluid replacement, and we're pulling everything off, but we're not putting anything back. These are your patients that have some type of a stomach virus maybe, and they're vomiting a lot and they're having a lot of diarrhea and they're losing a lot of that circulating blood volume because they're so dehydrated. And then it's also your patients who have some type of surgery and they're losing blood if they've had some type of traumatic event. The internal bleeding, external bleeding, just maybe the woman who had a baby and she's hemorrhaging and has a large loss of blood. Gynecologic issues, obstructive issues, burns. We see a lot of fluid shift. Remember, we talked a little bit about burns, and after those patients suffer with that initial burn, we see that big shift in fluids to try and compensate. Well, when that happens, we lose a lot of that circulating volume. And then again with diabetes insipidus. So some of the laboratory tests that we might look at, we're definitely going to want to look at their hematocrit and hemoglobin. So if they're losing blood, their hematocrit and their hemoglobin are probably going to be very, very low. If they're just losing fluid, their hematocrit and hemoglobin could be high because the solutes of the blood cells are left behind when we take out the fluid. So I'm not going to ask you a question about what their hematocrit and hemoglobin would look like. I just want you to understand that these are the tests that we would look at, and we might see a variability in them depending on exactly what condition is happening with the patient. So increase with dehydration because all the water is out, and then decreased obviously if they're hemorrhaging because all those blood cells are being lost. So you guys can take a look at page 244, table 17-2. It's going to talk about the different classifications of hypovolemic shock. So any time a patient reaches about a 30 to 40% loss, they're definitely going to require, even the 15 to 30% really, they are going to require some type of intravascular replacement, depending on what it is. 30 to 40%, they're going to require probably a blood transfusion and then a higher level of fluid replacement. Anything that exceeds 40%, so if you think about losing 40% of your circulating blood volume, that's definitely going to be a life-threatening condition. So this is something that I got off the internet. This is just a clinical picture of what you might see in a patient that has hypovolemic shock. We have to think that this patient's not getting any blood flow for some reason to any of their organs, including their brain. So we're going to see that altered mental status. They might be disoriented. They might be restless. In the initial stages, we're going to see tachycardia because the heart's trying to pump faster because it's compensating. It knows we don't have a lot of circulating blood. Dyspnea, short of breath. We're not getting that good oxygen-rich blood throughout the body. If we're losing blood, our skin may be cool and clammy. If we know that there's an obvious sign of bleeding. Decreased urinary output. If they have a Foley, you may or may not be able to see that right away, or you may just recognize, hey, this patient hasn't gone to the bathroom in a while. They're definitely going to have hypotension, obviously, because blood pressure is representative of our circulating blood volume. So they're going to need IV fluid replacement and then maybe a blood transfusion, depending on exactly what's causing that loss of blood. So distributive shock. So distributive shock is one of these types of shock that actually causes our body to vasodilate. So all of our vessels in our body are normally exactly where they should be. Instead of constricting and getting really small, they dilate and they get really big. And then this increases our capillary permeability. So this would be our neurogenic shock, our septic shock, and then also our anaphylactic shock. So all of these things lead to distributive shock. So neurogenic shock is when sympathetic tone and causes this huge amount of vasodilation. So things that may cause neurogenic shock, if patients are in some type of a traumatic accident and they have any kind of head trauma, if they have any kind of spinal cord injury, if they've had anesthesia, maybe if you think about the woman who has an epidural, or if they're having some kind of surgery on their back and they have to give them an epidural, if things go wrong, this can cause neurogenic shock. So neurogenic, also got this off the internet. So spinal cords, anesthesia, anything that messes with our vasomotor center and depresses that. So people that take drugs, if we give them too much pain medicine, low blood sugar is another thing that can cause it. So what we're going to see is this big vasodilation. All those vessels are going to open wide up. Our vascular resistance is going to be very, very decreased because there's nothing for it to pump against because it's so wide. It's just kind of like loose and hanging out there. We're not going to be able to get good cardiac output. Our organs aren't going to be perfused. And then it's going to go down from there. Anaphylactic shock, this is usually what someone suffers when they're having some type of an allergy. So some type of allergen exposure is going to cause this antigen antibody reaction in the body, and how it reacts is it causes massive vasodilation. So we're going to see that our capillary permeability is going to be increased. Our airway is going to start to swell. Our subcutaneous tissue is going to swell. We're going to have low blood pressure, and some people may have hives. Not everybody gets hives, but some people may. It is something that we see. So anything can cause anaphylactic shock. Obviously, foods is a big thing. Medications is another thing. Latex, people that are allergic to bees and spiders, things like that. So signs and symptoms, low blood pressure, because we're having that vasodilation. So low blood pressure, they may have hives, they may complain that they're itching, you may see a rash. You may not see anything on the outside, but they may complain that they're having difficulty breathing. So that's that tissue and airway swelling that's occurring inside that we really can't see. So definitely monitoring those vital signs, looking at O2, things like that. So this is just what the anaphylactic reaction looks like. Anaphylactic reactions are usually very, very quickly. They happen very quick. They're going to complain of shortness of breath. They're going to have that swelling inside their throat. They may feel like that feeling of impending doom. We've talked about that before. They just feel like things aren't right. They might complain that they have tingling in their mouth, swelling in their mouth. Their lips may swell up. But definitely that low blood pressure, increased heart rate, again, because it's trying to compensate. And then if things can continue to progress, then maybe even loss of consciousness. Whoops. All right, so septic shock, we also call it toxic shock. This is caused by endotoxins and other different things that cause massive vasodilation. So septic shock is actually can be very challenging to treat, and it happens very, very quickly. And despite how aggressive we are treating it, there's still a 60% mortality rate. So that's more than half the people. So that's not really good numbers, in my opinion. Some of the things that cause septic shock are gram-negative bacteria. So any type of a bacterial infection. So E. coli, big E. coli infections come from UTIs. That's one of the biggest, especially in women, one of the biggest things that causes UTI. Pseudomonas, Staphylococcus aureus, we just call it staph infection. Urosepsis in the older adults, like we talked about, is the most common one that we see. For a number of reasons, just because they are holding onto their urine, they can't concentrate their urine as much, they still retain some, maybe because they've had a catheter, things like that, or they have a UTI that isn't noticeable at first. And that's the thing about older adults, is usually they don't present with that, burning and frequency that normal people do. So it progresses and then we don't really notice it until they become septic. So signs and symptoms that someone is septic is they would have a fever. They may be warm. Their skin may be flushed because of the because of the fever. They're definitely going to have an elevated heart rate. Because of that elevated heart rate, their pulse is going to be bounding if things progress. So all of those are your initial compensatory mechanism. As things continue to progress, the body's going to try and preserve any kind of blood that it can for its main organs, the kidneys, the brain, things like that. So your lower extremities are going to start to get cold, your hands, your feet, your skin's going to become pale, and definitely you're going to be hypotensive. So in the hospital, we have, I'm not going to test you on this, but in the hospital protocols to recognizing septic shock. And one of the things we think about to determine if someone has septic shock is the rule of 100s. And the rule of 100s is that when we're looking at their vital signs, their heart rate is above 100, their temperature is above 100, and their blood pressure is below 100. So if any of your patients have those three indicators in their vital signs, then that kind of starts to make you think, hey, maybe something's going on with this patient and maybe they're starting to become septic. It doesn't mean that every single time your patient has that they definitely have. It's kind of like, that light should be going off and you should be saying, maybe we should do some more tests. They might be septic. So eventually what's going to happen is this shock is going to turn into multi-organ dysfunction syndrome. So it's going to affect all the organs, and then it can become very deadly very quickly. So laboratory tests that we're going to be doing, we're definitely going to be doing blood cultures. If we think anybody is septic, we're going to draw 2 sets of blood cultures, one from a different extremity, each one from a different arm, send them off. We're going to do urine cultures if we can get a sample. And then we're going to do, if they have any open wounds, we're going to want to take a sample of those wounds as well to determine what the bacteria is that's growing and if that's where the infection is. We're also going to be looking at our complete blood count. So we're going to be looking at our white blood cell count because we want to see if that's elevated, because that obviously is a sign of infection. And remember, our white blood cell count, our normal ranges are 5 to 10,000. All right, so, sorry. All right, so this chart here, I like this. So this talks about SIRS. So SIRS is just some type of, this is where the patient is, where we think maybe they have an infection. We're not really sure 100% yet. They don't have a diagnosed infection, okay? So they have a temperature, their heart rate's elevated. They may have an elevated white blood cell count, but we don't physically on paper have a known infection. Once we find a known infection, then it turns into sepsis. So we SIRS, and then we have a known infection. So we got a urine culture back that showed E. coli, or we got blood cultures back that were positive for something. So all of those, the temperature and the white blood cell count, all of those abnormals make up the SIRS, plus an infection. Those two together make sepsis. Then severe sepsis would be sepsis, which is a known infection and those abnormal vitals, plus now we're starting to see end organ damage. So our creatinine, our BUN, our liver function, all of those numbers are starting to go out of whack, and we're starting to see a lot of damage to our organs. Then it's going to progress to septic shock, and septic shock is severe sepsis and then hypotension, and that makes up the septic shock. All right, obstructive shock. So obstructive shock is anything that interferes with our blood being able to pump out of our heart effectively or back into our heart to get oxygenated again. It's definitely it's a result of usually some type of a non-cardiac issue that's causing our heart not to be able to pump. So pulmonary embolisms, any type of blockage in our vessels, pulmonary artery stenosis, if our arteries get very, very constricted and we can't get the blood through, ascites, pneumothoraxes, cardiac tamponade. We're going to talk a little bit about that this semester. Ascites, which is swelling in that abdominal area, and then So what happens is our heart is pumping, but it has a very high afterload. So it's pumping against basically a very high gradient. So the back pressure leads to venous congestion, and then it leads to vasoconstriction because it's trying to hold on and maintain the normal blood pressure. And then despite all of that, basically our organs still end up not being perfused. And because of the constriction, we have a decreased amount of blood. And I'm not going to quiz you on obstructive shock. There's nothing on the exam. Cardiogenic shock is a failure of our heart to be able to pump effectively. So that's going to affect how much blood comes out with each pump. So it's going to decrease our cardiac output. So every time our heart pumps, the amount that we normally put out is going to be decreased. So cardiac pump failure, a heart attack, just regular CHF heart failure, cardiomyopathy, any type of dysrhythmia like AFib, if there's some kind of rupture in our valves or any kind of valvular stenosis. So older patients are at an increased risk for developing MIs and cardiomyopathy. So we do see this a good bit more in our older population than we do younger people. Things that we would look at, we would definitely look at troponins. Troponins will tell us, it's a lab value that we take. Usually we take 3 of them about every 6 to 8 hours apart, and we trend the value. And usually if the patient's having a heart attack, those lab values start to trend in an upward direction, and they get higher each time. And that would be indicative of a heart attack. And then we can also look at creatine phosphokinase, and that'll tell us if there's anything going on with the heart as well. And this is just another slide that I grabbed off the internet. You guys can look at that. Whoops. All right, so these are the different stages of shock. I thought this was a pretty good example for you guys to look at. So we have 4 stages. You do need to know the 4 stages of shock and what occurs during each stage. We have the initial stage, the compensation, the decompensation, and the irreversible. And they are pretty self-explanatory. During the initial stage, sometimes we don't see any changes in the patient at all. All the changes that are happening on the inside, but they haven't gotten to the point yet where they're causing anything that's recognizable by us. So things are just going on in that cellular level. So let's see. What will happen is whatever's causing the stage of shock, no matter what it is, if it's cardiogenic or it's a UTI, whatever it is going to cause an issue with our blood pressure. And then we're going to see our sympathetic system start to come into play. We're going to increase the heart rate. We're going to see that renin-angiotensin activation, trying to get that blood pressure up. What happens? That's all during the compensation stage. And that makes sense. So any of our compensatory mechanisms we're going to see during that stage. Then the decompensation stage is basically the body tries to compensate, but nothing happens. So the process still continues. Nothing really gets resolved. None of those compensatory mechanisms work. And then because of the decreased blood flow and the hypoxia to the body, we're going to see all these initial changes. So cellular hypoxia, anaerobic metabolism, all of this stuff. And then it's going to continue to continue until we have organ failure. So during the compensation stage, the body's going to do what it has to do to increase the cardiac output to make sure that all of our organs can be properly perfused and oxygenated. We know just from 111 last semester that this happens in our body. It's something, it happens on its own. It's just how our body works. It wants to always create that normal homeostasis in our body. So we're going to see that our catecholamines come into play. They're going to help stimulate that sympathetic nervous system. We're going to increase our heart rate. We're going to increase how hard and how fast our myocardium contracts to get more blood out each time. The thought is that that's going to increase our venous return back to our heart. And then it's also going to cause bronchial dilation so that we can get more air in and more oxygen in. The renin-angiotensin aldosterone system is also going to come into play. This system we know by there's a couple different cascades that it goes through, but the end result is that it's going to restore our blood pressure and increase that circulating blood volume so that we get more blood to all of our organs. So you guys do need to know for your exam what the renin-angiotensin aldosterone does, and the goal is that it's going to restore that blood volume. Then we're going to see antidiuretic and corticosteroid hormones. We're going to see that ADH and ACTH is going to help control that sodium and that water balance. So we know that if we can hold on to sodium, water will follow. So if our blood pressure is low, the kidneys are going to hold on to more sodium and more water is going to follow, and then it's going to bump up our blood pressure. All right, so the decompensation stage. So this is where all of our compensatory mechanisms are not working. All of our cells are going to become hypoxic. We're not going to have the proper amount of oxygen. We're going to start to see cellular damage and destruction. This is the stage where metabolic acidosis can occur if it's going to occur. And you guys need to know that for your exam. We might see coagulation defects. Our body's going to create this inflammatory response in our body. Sometimes our bodies will develop these little microemboli that circulate throughout the body, which can go to your lungs, it can go to your heart. Sometimes they clump together and they cause a bigger, DVT or a pulmonary embolism. And then more detailed cardiovascular changes. So we're going to see, because we're not getting blood and oxygen to our myocardial cells, the patient may have a heart attack. And then our heart's not going to be able to pump at a normal sufficient rate each time. And none of our organs are going to be perfused. Whoops. All right, and then the irreversible stage. So that's pretty self-explanatory. Shock at this point is irreversible, and everything in the body is going to completely fail. So we're going to have a lot of significant damage to our cells and our organs. Usually, no matter what we do at this point, once it gets to this point, the body does not respond to any medical interventions. And then the patient has what we call multi-system failure. So no activity in the brain, the liver shuts down, the kidney shuts down, and then death is pretty imminent once you get to this stage. So for you guys, what do you guys need to know as your assessment? So primary assessment is we're going to look at things that will tell us if our patients have any type of issues that are compromising their circulating blood volume. So we're going to be looking at vital signs. We're going to be looking at the heart rate. We're going to be looking at the blood pressure. We're going to be checking pulses, right? We're going to we can do radial pulses, which is always a good idea. But if we're having if the patient's in shock and we're having any kind of, anything's compromised within our blood volume, we know that our body is going to try and just keep the blood where it needs it to. So it's going to kind of shunt it and keep it away from our lower extremities. So we might still have good pulses in our radial pulses because it's so close to our heart, but our lower extremities, not so much. So we may have very weak or very thready pulses on our posterior tibials or our dorsalis pedis pulses. We're definitely going to be doing a good level of consciousness assessment on our patients. So making sure that they know who they are, where they are, name, date of birth, all that good stuff. So look, because the brain is an organ too, and we know if we don't get that good oxygen, we're going to see changes in their level of consciousness. We're going to be looking at the color of their skin. We can look at their gums. Are their gums starting to turn pale or blue? Or is their face pale? And then we can always look at their urine output, because if the kidneys aren't getting enough oxygen or enough blood flow, then we're not going to be able to make any urine. And that's one of the telltale signs that there's really something going on in our body. Some in the ICUs, I'm not going to quiz you on this, but in the ICUs, they use something called the Apache scoring system. Basically, the higher the score, the higher the risk for death. What it looks like is it looks at acute issues, physiology, it looks at the patient's age, and then a list of their chronic health issues. So they usually use these in the ICU. You don't have to worry about that. Things that you may see with the patient, they may say that they're having chest pain, especially if their heart is being deprived oxygen and they're having an MI. They may be extremely lethargic. They may be very restless because of that lack of oxygen. They may be anxious. They may definitely be short of breath with exertion or at rest. They could be sweating. They may be complaining that they're very thirsty, because remember the hypovolemia, especially if they're dehydrated. They may have nausea, constipation, and then muscle weakness. When we look at their blood pressure, we know that they are going to have decreased blood pressure with a very narrowed pulse pressure. They're definitely going to be posturally hypotensive, so they're going to have that orthostatic hypotension when they sit up. We are going to be monitoring their blood pressure pretty more than every 4 hours. And if they're in shock, they're probably going to be in the ICU. So we can monitor their blood pressure by putting a cuff on them and then just recirculating it, or we can do intra-arterial, and that definitely has to be done in the ICU. We're going to be, remember, initially when the body's trying to compensate, we're going to have tachycardia because it's just beating away trying to get more blood out. The heart can only do that for so long. If things don't change, the pulse is going to, or the rate's going to become very weak, and then it's going to be very thready, and then it's going to progress to bradycardia, very low. And then we may see that the rhythm is irregular. So we're not going to really have that good lub-dub. It's going to be an irregular. Our respirations are going to be very shallow. They may look like they're air hungry. They may visually have accessory muscles showing. They may have that work of breathing. And then eventually, as things progress out of that compensatory stage, the rate's going to decrease. So initially, their respirations may be increased, but then decrease as things progress. They may have temperature. They may have a lot of heat loss. And then as things progress, their temperature is going to get very low, and it's going to be subnormal. Mentation, so obviously as things progress, their level of consciousness is going to be altered. Their skin is going to be cold and clammy. It could be mottled. It may take longer for that capillary refill because we don't have that good blood flow. And then cyanosis. And then definitely we're going to see changes in the urine output. So very, very little urine output, which is oliguria. And then we're going to start to see that renal damage. So if we're looking at lab values, BUN, creatinine, we're going to start to see those levels increase. Those lab values increase because the kidneys are damaged. So we know that the best way to determine if our patient does have metabolic acidosis, or if they're really hypoxic, is to do that ABG. And you guys need to know that. That's going to be on your exam. So we're going to want to have respiratory therapy come and do that ABG so we can really have a good, accurate measurement of what our levels are inside of our blood. Monitoring their central venous pressure. That's the pressure inside the right atrium. That, again, is going to happen in the ICU. That wouldn't be on a med-surg floor. And what we might see is that the patient is hypovolemic, which is a low blood volume, or they might be cardiogenic. So they might have a lot of venous congestion due to the low cardiac output. We might look at pulmonary arterial pressure. That's the pressure on the left side of the heart. I'm not going to quiz you on that. That definitely is done in the ICU. And then they may also be checking the PCWP, which is the pulmonary capillary wedge pressure. And usually for someone that's in shock, that would show lower than normal. But again, that's in the ICU. So, nursing process. So you have to understand that treatment is going to be very aggressive because time is not on our side, right? We said that shock progresses very, very quickly. So we need to be able to work quick to try and give them good resuscitation measures to try and reverse this process. So oxygen status always is a priority, right? ABCs, airway, breathing, circulation. So oxygen status, getting that ABG, seeing if they're hypoxic, giving them oxygen. We're going to be listening to their heart sounds and their lung sounds. So we're going to be listening for any type of fluid overload in the body. any type of abnormal heart sounds. So if they have a lot of fluid in their body, or if they have that irregular heart rate, we'll be able to hear that. We're going to be monitoring lab results. So we're going to be looking at hematocrit. We're going to be looking at hemoglobin. We're going to be looking at liver function, AST and ALT. We're going to be looking at kidney function, creatinine and BUN. All of these things that are going to tell us how our kidneys are, how our organs are doing throughout this process. And then, of course, strict eyes and nose, because we want to see if they're making urine. They're probably going to be on a continuous cardiac monitor because we're worried about the cardiac status. These patients need to have total rest. This takes a lot out of their body. There's a lot of things going on in their body. So we kind of want to make them be on bed rest and restrict their activity to a very low minimum. We want to make sure that they have a patent IV, probably a 20, because we have to prepare for blood transfusions and high amounts of fluid. We're going to be monitoring their skin color, right? Is it nice and pink, which means it's adequately perfused, or is our body starting to shunt our, blood to the places where it really needs it? And now our lips may be blue, our face may be pale. What's our temperature? Do we have, we have a subnormal temperature, so it's lower than normal, which means things are really progressing, or maybe we're just in the initial stages and we have a high temperature. Capillary refill, skin turgor. We're definitely going to want to do neurovascular checks as well. We're going to talk a little bit more about neurovascular checks when we talk about stroke, but we're going to be maintaining that level of consciousness. Do they have any weakness in their extremities, pulses, things like that? If they have any bleeding, that we can actively see, we're going to try and control that and get in touch with the doctor if we do notice bleeding from somewhere. And then at any time, we should always be prepared to intubate the patient. So we always want to make sure that you have any emergency equipment ready at all times. So when you go into that room, making sure that when I talk about emergency equipment, you should have an ET tube in a bag. Respiratory will usually come with that, but you should definitely have an EMBU bag. You should have suction tubing. You should have a Yankauer. You should have oxygen, a little Christmas tree to hook up the oxygen. Those are some of the things that you would want to have in that emergency kit in the room. So we should anticipate that the patient is definitely going to get some type of IV fluid. So we're trying to boost up that circulating blood volume. So sometimes if you think maybe a Jehovah's Witness, maybe they've lost blood, but we can't give them blood, right? So there are other supportive things that we can do to help in the meantime. So we could give them a crystalloid solution. We could give them albumin. Albumin is like a water magnet. Whenever you give albumin, water follows. So if we gave them albumin, the water would come in and it would increase our circulating blood volume. If they do not have any reason why they can't get a blood transfusion, then definitely we can give them packed red blood cells. Lactated ringers in 0.9% is one of the 2 medications that we usually give whenever there's low blood pressure or a patient's in shock. When we think about different medications that we give, definitely these patients are going to get a lot of vasopressors. So vasopressors work to strengthen the heart's contraction. So every time it contracts, it's going to make it contract harder so that it gets more blood out with each time. And then it increases that cardiac output, which in turn will raise the blood pressure. So these medications that we give, usually dopamine, norepinephrine is another one, vasopressin is another one. We can give these through a central line. We can also give them through an IV. But if these patients are in the ICU, they're probably going to have a central line. We can also give medications like digoxin, dobutamine, and miloroni, which are inotropic agents. These work together by strengthening the cardiac contraction and then increasing that cardiac output. So you should know the names of these medications and you should know what they do. Depending on what's going on with the patient, they may need other types of interventions. I'm not going to test you on these, but some patients, if they're having aortic issues, they might go in and try and open up that area by putting a balloon pump in. They may need some type of VAD device, which is a ventricular assisted device if they're having problems with their ventricles. And then there's something called a pneumonic anti-shock garment. I've actually never seen that done in an ICU. But those are other things that the patient could have done to help manage that shock.
Hello? Okay.
Hello?
Sorry, just cut off for a second, but I'm fine.
All right. So shock prognosis. Obviously, the earliest that we can identify this in our patient, the better the prognosis is. But remember, it accelerates very, very quickly. But we worry about these things which are our life-threatening complications. So kidney failure, multi-organ failure, kidney failure, liver failure, not getting enough oxygen to the brain. We worry about those neurologic deficits, level of consciousness, bleeding disorders, acute respiratory distress syndrome, stress ulcers. So sometimes the patients can develop ulcers from stress in the body that can cause bleeding. And then if they become septic, obviously. So it just depends what the prognosis is. So multi-organ dysfunction syndrome, MODS, this is where all of our organs start to shut down. So whenever we have anything in the body that causes our blood pressure to drop significantly, so when they develop severe hypotension, or anytime we have any cells in the body that have been deprived of oxygen or blood flow for an extended period of time, once we reperfuse them, it can also cause multi-organ dysfunction syndrome to develop. So it is something you have to watch out for, and then that will actually continue to cause issues on our tissues even further. Inadequate tissue perfusion can cause organ failure. We can see it in our lungs, so we can develop respiratory distress syndrome, respiratory failure. Kidneys can shut down. The heart can stop working. Our heart can decrease the amount that it contracts, so it won't contract as strong as it used to be, so we're not getting out enough blood each time. And then we can see, because we don't have that good blood flow to our GI tract, things can start to become necrotic from not having any blood flow there. Another thing that patients develop is disseminated intravascular coagulation, which is DIC. This is a side effect of someone who developed septic shock. What happens here is that there's a lot, like thousands of very teeny tiny small clots that start to form in our capillaries. Because the blood flow can't get through, then the body becomes hypoxic. And then we don't have the body loses its ability to be able to make clots to stop bleeding, and then the patient's at risk for hemorrhaging. So I actually saw this happen in a patient one time a couple years ago. A young patient, she was 25 years old. She had a daughter 2 years old, and she had some type of elective surgery. It was some kind of cosmetic procedure, and she had internal bleeding as a side effect after the surgery. And by the time they realized she was bleeding, she also started to develop this DIC. And this, in her case, was fatal. She actually died because you just hemorrhage because your body can't make anything that it needs to make the body stop bleeding. So what you would see is that the patients are going to get a lot of petechiae, so all those little red purplish spots all over the body, lots of bruising, and then anywhere where there's a puncture site or any of our membranes, they will bleed from. So we can bleed from the nose, sometimes from the eyes, from the ears, definitely from the mouth. If they have an IV site, you might see out of there. If they have any open wounds anywhere, blood coming from those areas as well. And that is it. Any questions about shock? No? No questions? All right, let's what time is it? It's 7:03. So let's start on introduction to the nervous system. See how much we get through. And then maybe we won't have to go the whole time on Tuesday. You guys doing okay? Can you hear me?
Yeah.
Yes.
Okay.
Yes.
Let's see. All right. Let's see. All right. So introduction to the nervous system. So some of this stuff is just going to be kind of like a refresher, just a lot of anatomy and physiology back from your biology course. I'll tell you if there's something that you guys need to know that's going to be on your exam. So these are your objectives. All right. So our nervous system plays an extremely important part in all of our bodies. All of the things that happen in our body. So it basically controls all of the systems in our body. It helps with our motor, our sensory, our autonomic functions in our body. It helps, it initiates cellular activity throughout the body, and it actually coordinates it. And it's definitely responsible for those electrical impulses that help us with our movement and our ability to breathe on our own without thinking about it, and a lot of different hormones as well. So if our nervous system is impacted anyway, we're obviously going to see noticeable issues. So our nervous system is actually broken down into two categories. So we have our central nervous system, which is our CNS, and then we have the system, which is our PNS. We have our motor neurons. Our motor neurons are the dendrites and the axons. So they're responsible for creating these impulses. These impulses travel along all the neurons in our body and go in through these different synapses. They come in contact with neurotransmitters. If you remember from 113, our neurotransmitters either inhibit our neurons or they excite them and cause something else to happen. Then we have this myelin, which is this fatty substance that actually is a protective covering for all of our axons. So you'll see when we talk about different issues that happen in our nervous system, sometimes our myelin sheaths aren't there, and those axons become uncovered, different things to develop as well. All right, so this is I like this slide. A lot of people struggle with the peripheral nervous system and what it's responsible for doing, and the central nervous system. So you guys can look at this. It may help you try and, I don't know if I got this out of your book or not, but it just kind of helps organize things and what is responsible for what areas in the body. So when we think about the parts of our brain, so when we think about our central nervous system is going to be composed of our brain and our spinal cord. When we think about the brain is going to be divided into three different parts. So we have our cerebrum, we have our cerebellum, and then we have our brain stem. The cerebrum has the cerebral cortex, which is located on that surface of the cerebrum. That is going to house all those motor neurons. That's going to help with our sensory neurons, so what we can sense, what we can feel. It's also going to be responsible for our motor neurons, which helps us be able to move. And then it's also going to help us to be able to receive impulses, from our peripheral sensory neurons that are going to be at different places throughout our body. We have motor tracts in our body. We either have pyramidal or extrapyramidal neurotracts. Our pyramidal motor pathways, they start in the motor cortex of our cerebrum, and then they end actually in our brainstem and our spinal cord. Those extrapyramidal fibers start also in the motor cortex, but then they're going to go out a little bit further, all the way to the cerebellum and the basal ganglia. Then we have our cerebellum, which is going to help control our coordination and our muscle movement. And then we have our brainstem. So our brainstem is responsible for our respiration, so our body actually being able to breathe on its own, our heartbeat, and our vasomotor activity. So any type of brain injury, any type of brainstem issue, you know automatically, well, hey, the brainstem controls the respirations, the heartbeat, and our vasomotor activity. So these are the areas where we're going to see difficulty in our patients if there's any kind of brainstem. And then inside of our brainstem, we have the midbrain, we have the pons, and we have the medulla oblongata. So this all should just be a refresher. So this is just a lateral view of the surface of the brain, which just kind of shows you where everything is. And then we have our cerebrum. So when we think of our cerebrum, we have two hemispheres. Each one of those hemispheres has four of the same lobes. So we have a frontal lobe, we have a parietal lobe, a temporal lobe, and occipital lobe. And this is important because these areas are responsible for different functions in the body. So all of them collectively have their own job that they do, but they control our ability to be able to reason. So to be able to hear someone speaking and be able to understand something, our perception of the way things are, our language, so to be able to hear and to be able to speak, and then our voluntary movement as well. So a lot of thought and a lot of learning. So this will come into play when we talk about strokes, and if people have a left-sided stroke or a right-sided stroke, it'll be pretty easy for us to be able to say, okay, well, someone had a stroke in this area and it affected this part of the brain, and this is where we're going to see a deficit in the patient. So this is actually a good slide. You might want to refer back to that once we start talking about stroke. The cerebellum is actually the second largest part of the brain. It is responsible for all of our involuntary movements. So things that just happen without us even thinking. Our coordination, so our muscle tone, so our strength in our muscles to be able to have that normal muscle movement to carry out like our activities of daily living. It helps with our balance. And then it helps with our equilibrium too. So being able to stand up, whether or not we feel dizzy. The cerebellum actually also coordinates our voluntary muscles and adjusts to different impulses that are happening in our body. And it controls our muscles, our joints, and our organs. So the medulla, which is located in the brain stem. Remember we said the brain stem is the midbrain, the pons, and the medulla oblongata. The midbrain is going to connect the pons and the cerebellum to those two central hemispheres that we talked about a slide back just on that 2 slides ago. And then the pons is going to be located in between our midbrain and the medulla. And it's also going to connect those two hemispheres of the cerebellum. The medulla oblongata lies below the pons, and it's going to be responsible for transmitting all of our motor impulses from our brain down to our spinal cord, and then all of our sensory impulses that come from that peripheral sensory neurons back to our. And then the medulla also monitors respirations, heartbeat, and all that vasomotor activity. So when we think about vasomotor activity, that's just all the control of the smooth muscle inside of our blood vessel walls. Let's see. Let's see if this works.
The brain is the command center for the entire body. It makes us who we are. It receives information from our senses and controls our thoughts and movement. To better explore this incredibly complex organ, scientists have divided it into parts and regions. The largest part is the cerebrum, which is divided into two sides called hemispheres, just like the Earth. The outer layer is known as the cortex, which is Latin for bark. Like a tree's bark, the surface is only 1/8 inch thick, but it also contains millions of cells with fibers that send messages to other brain areas. More than 2/3 of the surface of the cortex hides in hundreds of little folds that make the wiggly visible lines on the brain. Animals that are less intelligent have a smoother brain surface. The cortex is divided into 4 regions. The frontal lobe is for personality and emotions, higher thinking skills like problem solving and controlling movement. It continues to develop until you're in your mid-20s. The temporal lobe helps process your hearing and other senses, and helps with language and reading. The parietal lobe is involved with your senses, attention, and language. The occipital lobe helps your eyes see, including recognition of shapes and colors. The thalamus in the brain relays sensory and motor information to the cortex and helps with consciousness, sleep, and alertness. 12 pairs of cranial nerves carry information from your senses to and from the brain and body. Lower in the brain, we find the cerebellum, which plays a key role in motor control, coordination, and spatial navigation, so we can find our way out of a maze, for example. Underneath is the brainstem, which connects the brain to the spinal cord, a nerve pathway that runs all the way down your back, sending and receiving information from your senses. The brainstem includes the pons, which helps control our breathing, and the medulla oblongata, which regulates our heart and other body reflexes like vomiting, coughing, sneezing, and swallowing. The limbic system, a region under the cortex, processes our emotions and drives. It contains the brain's reward circuit, which releases the chemical dopamine, making us feel pleasure. The anticipation of pleasure motivates us to repeat important human behaviors like eating, having fun with friends, or falling in love. But it also encourages us to repeat risky behaviors like taking drugs. Drugs signal the brain to release unusually strong amounts of dopamine. This flood of dopamine causes the high that drug users seek and makes it difficult to enjoy more normal, simple pleasures. Repeated activation of this reward pathway can lead to addiction. The limbic system includes the amygdala, which processes emotions, and the hippocampus in the temporal lobe, which is like a memory indexer. It sends memories to certain parts of the brain for storage and retrieves them when you need them. The brain controls many actions through rapid nerve impulses, but there are some body functions that the brain modulates over many hours or days by secreting hormones via special glands like the hypothalamus, which wakes you up in the morning and gets the adrenaline flowing, like during a test or athletic event. The pituitary gland, often called the master gland, which helps control growth, body temperature, pregnancy, and childbirth. And the tiny pineal gland, which helps to control sleep and circadian rhythms. These are just a few of the parts and functions of the beautiful, amazing, and complex human brain. It is the center of our world and seat of our intelligence. We must exercise it, protect it, and understand how important it is to every thought and action in our daily lives.
All right. So that was a pretty good video. It definitely details everything that goes on in the brain. So you guys, it might be helpful for you guys to revisit that again once we talk more about strokes. And then once we talk about strokes and where, you know, if it's the left side of the brain or the right side of the brain, it might make more sense as to the different deficits that you would see. All right, so this is just a slide that shows you the central nervous system. So we know our central nervous system is our spinal cord and our brain. And we also have inside at the base of our brain, we have our skull, which we know is that hard outer area of the brain that helps protect our brain, the bones. Whoops. Then we have the meninges, which are the different layers of the vein. If you look over here, we have the different layers that help cover the brain to protect it. So we have the dura mater, the arachnoid, and the pia mater, and then we have our subarachnoid space in there, which is the very smallest layer closest to the brain. And then we have our ventricles. So what our ventricles do is they help make and absorb CSF, which is cerebrospinal fluid. So the purpose of having cerebrospinal fluid is it helps to protect the different structures inside of our brain and our spine, and then it helps to maintain the pressure inside that intracranial space, because we don't want too much pressure because then things will become swollen, and then if we get too much swelling in that area, then it's going to cause damage to the brain. And then we certainly do need a certain level. We don't want to have too less because that would also cause issues as well. Then we have our spinal cord. Our spinal cord is also basically made up of the meninges and the vertebrae. So the vertebrae is just that vertebrae column that we saw that runs from the top of the, from the base of the head down to the lower spine. Our spinal cord will help with our reflexes, and then it's also going to provide that good structured and closed pathway for our impulses to come from our brain throughout our body. And we have our peripheral nervous system. So our peripheral nervous system is our parasympathetic nerves, our sympathetic, our spinal nerves, and our cranial nerves. So we have a lot of different cranial nerves. I'm not going to test you on any of them. You just need to know that they exist. But the PNS includes the cranial, the spinal, the sympathetic, and the parasympathetic nerves. You will talk more about cranial nerves if you come back for the transition program and the nursing program. So we do have 12 pairs of cranial nerves, and then we have 31 spinal nerves. So we have dorsal spinal nerves, which are responsible for all of our sensory in our body. And then we have ventral nerves, which are responsible for our motor actions in the body. Then we have dermatomes, which are different areas in the body, different nerves that help innervate a specific area in the body. So this is just a list of all of the cranial nerves that we have. We have an olfactory nerve that's going to help us to be able to have a good sense of smell. We have our optic nerve, which helps with our vision. We have our oculomotor nerve, which helps our iris contract and it helps control our eye muscles. We have our trochlear nerve, which is going to help control our eye movement so that we can see all around. We have our trigeminal nerve, which is our sensory nerve in our face, and it affects our chewing. We have an abducens nerve, which also contributes to some aspect of our eye movement. We have our facial nerve. So this is going to help with our facial expression. It's going to help with how we taste food, and it's going to help with our secretion of salivary and lacrimal glands. Vestibulocochlear, or our auditory nerves, which is going to help not only with our hearing, but also our balance. We have our glossopharyngeal nerve. So this also has something to do with how well we taste, our sensory fibers of our pharynx and our tongue, how our ability to be able to swallow, and our parotid gland. And then we have our vagus nerve. So this is responsible for helping to make those digestive enzymes that help break down our food. It's going to be responsible for our heart rate, our speech, our gastric motility, our breathing, our swallowing, our coughing, and our vomiting reflex. Then we have accessory muscles, also known as our spinal accessory muscles. These help with our head and shoulder movement. And then our hypoglossal nerve, which controls the movement of our tongue. So this is just another slide that helps break everything down and show all the different nerves and what they control. Just another view of where these nerve fibers are found in the body, in the brain. And then the nervous system. So we talked about the central nervous system. So the peripheral nervous system is our sensory neurons. The PNS is going to consist of all the sensory and motor neurons outside of the central nervous system. So the cranial, the spinal, the sympathetic, and the parasympathetic nerves. So we have 31 pairs of spinal nerves that come from a column, but they're all going to be at different levels in the body. They're not all at the same place. I'm not going to quiz you guys on these, but we have 8 spinal nerves that are located in our neck. We have 12 in the thoracic area. We have 5 in the lumbar area, 5 in the sacral area, and 1 in the coccyx. Anytime that we have an injury, if the patient's in a car accident, or they break their back, or they sever their spine, or they break their neck, anytime there's any type of damage or injury in any of these areas, we know that we're going to have problems with our reflexes and different responses in the body. So any kind of brain injury, any kind of trauma to the spinal cord. Our autonomic nervous system is going to be responsible for, so the autonomic nervous system consists of your sympathetic nervous system and your parasympathetic nervous system. All of the things that it's responsible for are, when we think about what it does, are going to be all of our functions that are going to be essential to being able to survive. So the ANS maintains homeostasis by either stimulating or inhibiting different actions of our smooth muscle, our cardiac muscle, and different glands in the body. So the sympathetic nervous system is going to be responsible for our fight or flight response. Whenever there's actually an actual threat somewhere in our body, or if our body just even perceives that there's a threat. So we can think of sympathetic nervous system as stressed out. The neurotransmitters of our sympathetic nervous system, we call catecholamines, and those are our epinephrine, our norepinephrine, and our dopamine. So these are our fight or flight. So anytime we're in a stressful situation, anytime there's stress in the body, any type of intense emotion, or any type of severe illness in our body is going to release these catecholamines. And then our parasympathetic nervous system is the complete opposite. So the parasympathetic nervous system will conserve our body's energy, and it's going to slow down our heart rate, and it's going to slow down how quickly we digest food, and it's going to keep our body from body wastes. And that neurotransmitter that comes into play in our parasympathetic nervous system is going to be our acetylcholine. So this is just the anatomy, a picture of our autonomic nervous system. Oops. So when we are assessing our patients, so we always want to make sure that we do a very, very thorough assessment on our patient, a good head to toe. We want to make sure that we're asking enough questions so that we can explore all their symptoms and clarify each symptom that they have. So we definitely want to have a good history. So we want to know, have they had any trauma? Have they been involved in any accidents? Have they had any injuries to their spine or their neck or their brain? What type of medications do they take? Do they take any medications that could suppress the activities in our brain or our respiratory system? Do they have a history of any drug abuse? What is their past family like does anyone have Parkinson's or MS, things that affect our nervous system. We want to get as much information as we can about that so that we can try and put the pieces of the puzzle together. The whole time while we are asking them about their past medical history, we're also looking at the way that they speak to us. So are they able to reason what we're saying? Are they able to understand what we're saying? Are they responding appropriately? Do they have any delays in their speech? Do they have any alterations in their mental status? Are we trying, by talking to them, do we think that they're not completely alert and oriented? What's their intellectual functioning like? Can they reason? Are they moving? Can they walk normally? Do they have any issues with their gait? Things like that. Part of our physical examination that we do, we can do a mini mental exam on a patient. And that's if we think that maybe their mental health is compromised in some way, or if we think that they maybe have dementia. We can definitely do a mini mental status examination. We want to look at their posture. So are they able to sit up straight? When they walk around the room, do they have problems walking? Do they have weakness on one side of their body? These can be side effects or residuals from something that happened in the brain. Motor function. So when they're walking, we want to look at their, remember when we are looking at motor function or when we're doing our physical assessment, we're always comparing one side to the next. So we're looking for muscle atrophy. So if we have a patient, for example, that had a stroke and they have right-sided weakness, they might have, atrophy on that one side of the body. So we're going to be looking at each side of the body to see if we have muscle atrophy. Is one larger than the other? Is when we're doing checking strength, we're going to make sure that the strength is equal on both sides. We can make sure that we're doing the gas pedal test where we test their dorsiflexion and plantar flexion so they can pretend like they're pushing down on a gas pedal and then pulling their feet back. What type of dexterity they have? Are they able to pick up small objects with their thumb and their forefinger? Are they allowed to, can they really use their hands to pick up large objects? Things like that. And definitely we want to make sure we're checking their gait, movement, and balance. One of the things we do when we're checking a patient for their balance and their gait is we do a Romberg test. So this is a Romberg test. And you definitely need to know what a Romberg test is and what it's looking for and how to do it. We're going to have, this will be on your exam. So a Romberg test is a motor function assessment. It looks at the patient's muscle strength. It looks at their arm and their leg movements and their gait. So what you do is you have the patient stand up. They put both of their feet together and then their arms are going to be extended. Then we ask after they assume that position, we ask the patient to close their eyes. If the patient, after they close their eyes, starts to sway or they lose their balance at all, that's going to be an abnormal response. That is not something that we want to see. So if we're worried about their strength, we're worried about their gait or their movements or their muscle strength, we would do this Romberg test. Neurological assessment. So we definitely want to do good neurological assessments because this is going to tell us if there's anything going on with their spinal cord, if there's anything going on in their brain. So we can use the Glasgow Coma scale that we've talked about before. This is good. We use this in the ICU for evaluating their level of consciousness. This looks at verbal and motor responses. And basically, it's kind of like the Braden scale. You go in and you check off different responses, and it gives you a certain number. The normal response would be a value of, if a patient were to score a value of 7 or less, that would indicate that they were in a coma. So if a patient was in a coma, they would not be opening their eyes. They would not be able to interact with you. They're not obeying any command, and they're not talking any understandable words at all. This is that Glasgow Coma scale that I was telling you about. So we would look at their motor, their verbal, and their eye opening. So if they were able to obey verbal commands and to move and to follow instructions, we would give them a 6. If they didn't have any response to any type of stimuli at all, they would get a 1. So we would evaluate them, score them appropriately, and then determine what score they had. Some of the things that we see when there's been any kind of trauma to our nervous system. So sometimes if they've had brain trauma or they've been paralyzed somehow, they can take on these different postures. So we have decorticate and decerebrate posturing. So with decorticate posturing, they're going to be very, very rigid. Their arms are going to be flexed. Their fist will be very, very tight, and they're going to be clenched together. It's going to be very, very hard to open up their hands. And their legs are going to be extended out, very, very straight and very, very stiff. With the cerebrate posturing, they are also going to be very rigid, but their arms are going to be straight out. They're not going to be curled in, and they're going to be very, very stiff. The decerebrate posturing is much more serious, and it indicates a higher level of some type of damage to the nervous system when you see that type of posturing when compared to the decorticate posturing. Even more worrisome is going to be flaccidity. So this is where the patient just appears in that bottom picture, very relaxed. If you were to pick up their arm, they wouldn't be able to overcome gravity. Their arm wouldn't stay up. Motor response at all. And then they wouldn't be able to respond to anything. That's a very ominous sound when somebody has no motor response at all. And you should definitely know how to identify decorticate and decerebrate posturing. You should know the differences between the two. So when we think of our sensory function, so our sensory function is we can assess our sensory function with a patient by saying, do you have any numbness or tingling? So this is the patient being able to have complete feeling in their extremities or their hands, so they can express if someone's touching them. They can tell if they're in pain. They can tell if something is cold on their body. They can tell if there's heat on their body. So that's their sensory function. That is something that I ask all of my patients. It's actually my fall risk assessment. I ask them, do they have any numbness or tingling in their hands or feet? Because if they have numbness or tingling in their feet and they can't feel their lower extremities, then that puts them at risk, obviously, for having a fall. We also want to assess our patient's level of consciousness. We definitely do this every day. We're doing this while we're talking to our patient, giving meds. We're looking at them to determine if they're being able to reason, can they hold a conversation? Are they alert and oriented? Are their responses appropriate? So if a patient is completely conscious, they're going to be able to respond immediately. They're going to be very appropriate with their response. They're going to be able to hold eye contact with you. They're going to be able to hear. You're going to be able to tell that they're completely conscious. If they're somnolent, this is where the patient may appear drowsy at times. They may appear inappropriate. Sometimes they may fall asleep while you're talking. You may have to arouse them by shaking their arm or calling their name. Sometimes their responses are delayed, so you ask them a question and it takes them a couple seconds to answer. Or sometimes when they do speak, it may not be delayed, but it might not make any sense. They definitely still have response to painful stimuli during this stage. If a patient goes into a stuporous state, this is where the patient is only going to be aroused by vigorous and repetitive physical, auditory, or visual stimulation. So really taking the patient by the shoulder or by the arm, shaking them, calling their name. And we would expect that maybe the patient during this stage only responds with 1 or 2 word answers. You're not going to get a lot out of them. If they're in a semi-comatose state, they're going to be unresponsive except for mild painful stimuli. And they might not answer you at this point. They're just going to have some type of motor response. So if we were to take a needle and touch the bottom of their foot or their arm, we would expect them to move their foot or arm, but they probably aren't talking to us during this state. And then a comatose state, they have actually no spontaneous movement at all whatsoever, and their respiratory rate at this point is not going to be irregular anymore. So you guys remember Perla. We talked about this during fundamentals. So this is going to be pupils equal reactive to light and accommodation. So we're going to be looking, we're going to definitely need our pen light out, and we're going to be doing good assessments on these patients, especially if we think that their neurological status is not in contact. And we're going to be looking at, want to make sure that we're comparing one side to the next side. So are they a normal size? Usually on the side of your pens, they have different circles that correlate with different sizes of pupils. So you want to note what size they are, if they're a 3, a 2, or a 1. Are both sides the same size? Are they dilated? Are they equal? Do they react to bright light? Are they sluggish? Are they fixed, which means that they don't react at all? Fixed is not a good sign. Just always make sure you're comparing one eye to the other. You can use that Glossopharyngeal scale that we talked about. There's also another scale, which is the Rancho Los Amigos scale. I'm not going to test you on that, but it's in your book if you want to look that up. We want to look for different neck positions. So is your patient in any type of abnormal position at all? Did they appear very rigid? Are they complaining of neck stiffness? Neck stiffness is something that we see in a lot of patients that have meningitis. So that's something to think about. And then we want to definitely pay close attention to their vital signs. So we're going to be looking at their blood pressure, their pulse, their respiratory rate, their temperature. Remember, our CNS affects our temperature. So if there's something going on in our nervous system, our CNS has been compromised somehow, our vital signs are going to show. Another test that we can do, I'm not going to test you guys on this, is we can do a vibration test using a tuning fork. So what we do is we ask the patient to close their eyes. We strike the tuning fork and then we place it against the client's wrist and then their ankles, and then ask the client if they felt a vibration. If they feel that, then that means that their neurological system is intact. Precipitation, this is a sense of joint position in space. So is we ask the patient to close their eyes, and then we move a joint of the client's finger or an extremity up and down in that space where they're sitting. And we ask the client to be able to distinguish which way we're moving them, if it's up or down, or if it's to the left or the right. I'm not going to test you on that. Stereognosis, this is the patient's ability to be able to recognize an object by feeling it. So we would ask the patient to close their eyes, and then we would put something familiar in their hand. In this example here, we give the patient a key, and they have to keep their eyes closed and try and recognize what's in their hand. I'm not going to test you on that. Graphesthesia, I'm not going to test you on this either. This is the patient's ability to be able to identify letters and numbers if we draw it on the skin. So we take some type of a stick or a cotton-tipped applicator, a Q-tip, something like that, and we would draw letters or numbers on the patient's skin or objects like a heart or something like that, and they have to be able to tell us what it is. And then our reflexes. So reflexes are something that we definitely check, that they can have, they can definitely identify issues with neurologic assessment. So deep tendon reflexes, so we can do a patellar reflex. This is this specific hammer, and we put it between the thumb and the index finger, and we strike it over a certain muscle. Sometimes we do it above the knee right there, and then if the knee responds with a jerking motion, that means that their patellar reflex is in good standing and there's no issues with their deep tendon reflexes. We can do this with babies. We do a lot of this with babies, but we can also do it with adults to determine if their superficial reflexes are intact, we can take a sharp instrument, and what we do is we take it along the lateral border of the foot. And then once we rub that area, it produces an extension of the big toe, and it causes fanning of the other toe, just like you see in the picture. So we can do this in adults and children over 2. A positive Babinski sign can mean that you have some type of issue going on in your brain or some kind of issue in your nervous system. Whoops. So what kind of diagnostic tests we can do? A CT, we can do an MRI depending on what's going on. We can also do a PET scan, which is a little bit more involved, takes a lot longer, but it can look at different metabolic activity. And then we can do what's called a single proton emission computed peripheral nervous system tomography. So this is a much more detailed test. I don't think we've ever talked about this test. So this test will actually look at the anatomic structures, and it can give us information about how well our brain is functioning. So it can look at the blood flow to the brain, and it can look at the receptors for different neurotransmitters in the brain. So this test can actually help diagnose Alzheimer's disease and Parkinson's disease. We also do this test sometimes with patients that have seizures, and we can do this to get detailed information for people who have brain tumors as well. Another test that we can do is a lumbar puncture. So this is important. You guys will need to know this. Anytime there's, if we think the patient has a bacteria infection and we don't know where it's coming from, if we think they have meningitis or they have something going on in their brain, there's a lot of different reasons we may do it, but we can go in and do a lumbar puncture. So this is where we go in and we take a small sample of our cerebral spinal fluid, we take it out, and then we send it off to have it looked at to see what's going on. So we go in basically into the subarachnoid space in our cerebral spine, and we can measure the cerebral spinal fluid. So if we're losing CSF fluid, it can measure and tell us if we have too much or if we don't have enough. And it also looks at different pathogenic microorganisms. So anytime we pull cerebral spinal fluid out, we would expect that it's clear and that it doesn't have any color. If it's not clear and it's purulent or it has a certain color, then that's going to mean that there's something going on in the body. There's probably some type of an infection. When we check pressure, normal pressure inside the CSF is going to be 80 to 180. I'm not going to test you. A side effect of a lumbar puncture, though, that some people do experience is what we call a post-procedural headache. So if somebody has a lumbar puncture, it's common that after that, usually in IR where they have it, they have to lie completely flat for an hour to several hours after the test, just depending on what they did during the test, how much cerebral spinal fluid they had, how involved the test was. So at a minimum of 1 hour, sometimes up to 4 hours. And then they have to basically increase their activity slowly over the next 24 hours. And then they also increase their fluid intake as the day goes on. What happens sometimes is these patients will get severe headaches from this lumbar puncture. And what happens then is they have to go back in and they have to have what's called a blood patch. So that's where they would go back to IR and they would get 20 to 30 mLs of their own venous blood. We would withdraw it from just a venous blood draw, and they would go in and they would do what's called a blood patch. So they take that 20 to 30 mLs of the patient's blood and they put it back into that epidural space, and it causes the leak to seal. So if they have that headache, it's usually because they're leaking cerebral spinal fluid for some reason. So that's what you guys need to know. You guys need to know what you would do for a patient if they were suffering from a headache. That's going to be on your test. Depending what's going on with the patient, we can do nerve conduction studies to see if they have good nerve function. Use it to diagnose a lot of different neurologic disorders. We can do it to diagnose peripheral neuropathy. We do this all the time in our patients that have diabetes. and we can do it with carpal tunnel as well. So it basically looks at how fast the nerve impulses travel along that peripheral nerve. And then obviously if they don't travel at all, or if they have a decreased amount in how fast they travel, that's going to be a abnormal test. We can do an EEG, which records all of the electrical impulses in our brain. We can also do an encephalogram, which looks at the different structures of the brain as well. So if we think there's any type of intracranial bleeding, or if we think that there's some kind of abnormality in the ventricles in the brain, like a stroke or something like that, we can go in and look at that. And then we can also do contrast studies. So we can do a cerebral angiogram. So this would look at all of our cerebral arteries in our vein. It can identify aneurysms, hemorrhages, things like that. So some of our nursing diagnoses or nursing problems that we may see, obviously we may anticipate that some of these patients are going to have a knowledge deficit because they're not familiar with having these diagnostic procedures. So we want to make sure if there's any knowledge deficit there that we explain everything. We want to be very forthright with them, explain them exactly what's going to happen, make sure that we prepare them for the test. And we want to inform them if they're going to be in any type of discomfort, things like that, so that they know. Some patients may have an allergic response to the iodine or whatever it is, the dye that we're giving for these tests. So we're going to make sure that we are doing a good assessment beforehand to make sure that they don't have any allergies to contrast, and they're going to monitor them also through the course of the test to make sure that they're not having any type of allergic reaction. That we're always monitoring their level of consciousness. So we want to know what their baseline is before we do any of these tests. And so that way we can always tell if they're decompensating or not. We want to make sure that we're monitoring for any headaches or sudden pain that they didn't have before. And then really making sure that we keep that patient flat for the recommended time, 1 to 4 hours after that lumbar puncture. It says here 3 hours. It just really depends on how involved it is. So 1 to 4 hours is usually the window. And that is it for neuro. So why don't we take just a quick 10-minute break. We'll come back at 8 o'clock, and then we will start with 1:15. Does that sound good?
Ms. Davis?
Yes.
Before we get to that point, I did have a question regarding the lumbar puncture. I think
Okay.
it was slide 44. Is that something that we would ever take part of? I mean, what level on the food chain would that go to do that test?
So it's not something that we would do. You may be assisting in IR as a nurse in IR, but you would just be monitoring vitals. We don't actually do the lumbar puncture ourselves. The doctor does that, but certainly we could assist, and we would just be monitoring for side effects.
Okay, so that's not something we would do whether we are an RN or an LPN.
Actually performing it, no.
Correct.
No, nope, we don't do that.
From what it sounded like of anything that you had discussed that we would probably take any part of might be if they were having a headache to do the venous patch, because we could remove the blood, correct?
We could we could remove the blood, but we wouldn't put it back into the CSF area. Yep.
That's all the doctor. Okay, I was just curious whether that was something we would do.
Yep.
Thank you.
You're welcome.
So we can log out and then come back, or
you can just turn your mic off and your camera off and then come back. Yep.
Okay, thanks.